Let's talk about warfarin. Warfarin, first thing you got to know that it has a delayed action because it has to inhibit the vitamin K activation, right? So even if you give warfarin, the factors that are already present within the blood, they're already there. You're not destroying them, so they're gonna do their job, whatever they're doing, but eventually you have the effect by inhibiting the factor K. So let's read. It inhibits vitamin K epoxide reductase by competing with vitamin K itself, leads to inhibition of vitamin K dependent gamma carboxylation of clotting factor 2, 7, 9, and 10, and protein CNS. Metabolism affected by polymorphism in the gene for vitamin K epoxide reductase complex, VKO, not O, but I don't know, it's O or 0, I don't know, KORCI, RC1, in lab assay has effect on extrinsic pathway, intrinsic pathway increase in PTT, warfarin increase in PT. It has a long half-life. The ex-president went to war. PT went to war. Well, Trump ain't going to war, man. So I don't know if you want to memorize that or not, but let's move on. What do we have? Warfarin inhibits epoxide reductase, right? And leading to these factors, inhibition of a carboxylation of these factors. So they're not going to be carboxylated. That means they're not going to be mature, and not they're going to be inactive. And that's pretty much what we have for the mechanism. Let's look at clinical use. In clinical, you can use this in a chronic anticoagulation. Example of venous thromboembolism prophylaxis, prevention of stroke in AFib. Not used in pregnancy. Very important. Not used in pregnancy because warfarin, unlike heparin, crosses the placenta. It crosses placenta, and it is teratogenic. So not in pregnancy. You can monitor PT/INR. PT/INR. Adverse effects: bleeding, teratogenic effect, skin tissue necrosis. Very important. Look at this thing. Skin and tissue necrosis. Okay, you have a drug-drug interaction metabolized by cytochrome P450, CYP 269, so you can have a drug-drug interaction. Initial risk is of hypercoagulation because protein C has a shorter half-life than factor 2 and 10. So initially, as you give warfarin, you have a chance of hypercoagulation because protein C has a short half-life than factor 2 and 10. Existing protein C depletes before existing protein factor 2 and 10 deplete, and before warfarin can reduce factors 2 and 10 production. This leads to hypercoagulation. That makes sense. So initially, you are at the risk of having a hypercoagulable state. So skin tissue necrosis within the first few days of large doses believed to be due to small vessel microthrombosis. Okay, heparin bridging. That is, the heparin frequently used when starting the warfarin. Heparin's activation of antithrombin enables anticoagulation during initial transient hypercoagulable state caused by warfarin. First thing, as I mentioned, it has a delayed sort of its mechanism, right? Because all the clotting factors that are present within the blood, they're working. So they're saying give heparin, which is a really good idea. Give heparin. So these factors that are already present, they're not going to coagulation. They're not causing hypercoagulable state. So you're trying to control that. Start on warfarin. As it kicks in, you are inhibiting any factor. So you have no factors available now in the blood. Okay, so initial heparin therapy reduces risk of recurrent venous thromboembolism. So very important. Look, what are the benefits if we were to have initial heparin? You have reduced the risk of venous thromboembolism, skin tissue necrosis. For reversal of warfarin, give vitamin K, but this is again delayed. We talked about it. But for rapid reversal, give FFP or PCC. Okay. And let's talk about now the extra stuff. Bleeding, if you have an INR greater than 3, then you can bleed. So decrease the dose of your warfarin. Or if you have INR greater than 3. INR, man. Okay. So target the INR for therapeutic should be, let me see, target INR for therapeutic warfarin anticoagulation is 2 to 3 seconds. Okay. Elimination is through P450 enzymes. So look for concurrent drugs the patient is taking, inducers or inhibitors, and fix the dose to keep the INR at 2 to 3. Cholestyramine binds warfarin in intestine. So if you are giving somebody cholestyramine, it binds warfarin in the intestine. So although you're giving the drug and it's not working, you're like, whoa, what's going on here? I am not achieving my 2 to 3 INR. So what's really going on? That is due to the fact that you're also giving cholestyramine and you had no clue that cholestyramine binds the warfarin in intestine. When you bind something in intestine, take a poop, feces, no therapeutic effect. Okay. For this skin necrosis, skin tissue necrosis, this occurs because you have transient this is one of the adverse effects, and also occurs due to the fact that you have the initial hypercoagulation state. You can reduce this by giving heparin, reduces the skin necrosis. But how does it happen? Well, the difference in the half-lives, as we mentioned, that the protein C has a different half-life, which is a short half-life, and the factor 2 and 10 have greater or longer half-life. That leads into transient hypercoagulable state because of decreased protein C half-life, an increase in factor 2 and 10 half-life, and on top of that you have the persistence of all the factors 2, 7, 8, 9, 10 present within the serum. All of these factors, they cause procoagulant effect, right? Procoagulant effect leads to clot formation. That clot formation interrupts the blood flow to the skin, which leads to skin necrosis. So patient with pre-existing protein C deficiency, let's say the patient who already had a protein C deficiency, have increased this. If you already had a protein C deficiency, that increases the formation of skin tissue necrosis. So if you get this right away strop drug, give FFP, administer fresh frozen plasma. Okay, so that's all for the warfarin.